I'll just try briefly to talk about AFib epidemiology and outcomes and why it is important to prevent a stroke in those patients. Then primary stroke prevention by atrial fibrillation screening. And I think the most important nowadays is to have AF integrated management system. And one of the suggested systems is the AP system. We'll go over it quickly. So A, avoid stroke, and B, better symptom control, and then cardiovascular and other comorbidity risk reduction. So looking to the epidemiology of atrial fibrillation, more than 43 million patients had atrial fibrillation in 2016. In the past 2 decades, there is a significant increase in prevalence of atrial fibrillation, and it's expected actually to continue increase in the coming decades. This is in Europe, for example, but the same is seen in United States, same is in Korea and other Asian countries. So it's going to be increased with time. Why AF is important? Because of the related outcomes. It is a source of morbidity and mortality. Morbidity including stroke, LV dysfunction, cognitive function decline, depression, increased hospitalization. And when we look to the stroke, 20 to 30% of all ischemic stroke is related to atrial fibrillation, and it accounts for 10 to 15% of cryptogenic stroke. When we think of AFib-related stroke, we know the cardioembolic, but sometimes we actually miss what is important also, the vascular atheroma. So still, it could be cardioembolic or related to comorbid vascular atheroma. Atrial fibrillation screening is important, theoretically at least. So about 1/3 to 1/4 of patients with atrial fibrillation have no symptoms. And looking to patients with cryptogenic stroke, about 15% of them had paroxysmal atrial fibrillation not diagnosed before, with only 1 month monitoring of their rhythm. Dr. Muhammad showed you before that we have now mobile technology. It is easy to screen for atrial fibrillation and other arrhythmias with these technologies. So atrial fibrillation screening can be done with a simple thing like pulse taking when they come to the clinic. Automated blood pressure monitors can be done also with single lead ECGs, smartphone applications, or watches, as you have seen before. And it has good sensitivity, specificity. But remember, there is still risk with the screening. Yeah? You diagnose the disease early, you may start management early, but there is some risk, like an anxiety related to abnormal result of this screening test. Sometimes misinterpretation of the ECG result and mismanaging the patient. So overdiagnosis, over-managing patients can lead to harm. And sometimes there may be some other abnormalities in the ECG that need to be dealt with. In 2 largest studies looking to AFib screening, the stroke, stop, and loop studies published simultaneously in Lancet in 2021. The stroke stop enrolled more than 28,000 patients in 2 areas in Sweden. And if you look at the intervention, they look to invite half of those people or half of the population to come for twice daily ECG recording. This is a portable machine for 2 weeks only. And 51 of the participants got the machine compared to the control group. And they look to all-cause death, strokes, and bleeding. In the loop study, they enrolled patients 70 years of age or older with at least 1 risk factor for thromboembolism. And the intervention here is implantable loop recorder. Randomization was 1-3. And about 95% of the subjects randomized to the loop got the loop implanted. Looking to the outcome, AF diagnosis increased in the invitees from 12 to 20%, and oral anticoagulation use increased from 9 to 18%. So about 72 of the AF patients in the intervention group were in anticoagulation compared to 64. In the loop study, implantable loop recorders, as expected, increased the AF diagnosis. About 90% of those patients were in anticoagulation compared to 87 in the control group. But if you looked at the result, the primary outcome, it was just marginally positive in the stroke stop for all cause of morbidities and mortality in cardiovascular. And for stroke, it was negative. The same for loop study, stroke and systemic arterial embolism was not different between the 2 groups. There are many reasons. Maybe you can discuss it in the discussion. So screening recommendations, the 2020 European Society of Cardiology guidelines recommended the screening of opportunistic screening for individuals 65 years of age or older, and systematic for those who are 75 or older with, or those with high risk. And the United States Preventive Services Task Force did not recommend actually screening, but they are different because they look to younger age group, 50 or older. They did not include pulse palpation, which is a simple tool for screening. The second part, which is the atrial fibrillation integrated management strategy, the A, B, and C. This just tells you that the AFib is not only about stroke prevention. We have to prevent other factors. So A is avoid the stroke by risk stratify the patient. Low risk, no need for anticoagulation. High risk, they put in anticoagulation. Better symptom control is personalized management of the patient with atrial fibrillation, considering rate control or rhythm control. Cardiovascular and other comorbidities management is important to go hand in hand with the atrial fibrillation management. In this study, looking to the patient treated with integrated APC care compared to patient with usual care, there is significant reduction in all-cause death, composite outcomes, stroke, major bleeding, and myocardial infarction. In a systematic review, also, it showed that utilizing this APC pathway reduces all-cause mortality, cardiovascular death, ischemic stroke, and major bleeding. And just recently published prospectively evaluating this APC pathway in over 1,000 patients. 64 were in the adherence group and 37 in non-adherent group. Clearly, there is improved net outcome, MACE, and all-cause mortality in patients followed the APC pathway. The APC pathway was published in 2017, and it is actually recommended by the European guidelines and other guidelines, as you can see here. For the stroke prevention, a component of the APC, we know that we have CHA2DS2-VASc score, and it's recommended by most of the guidelines that we have to use the CHA2DS2-VASc score. The higher the score, the higher risk of thromboembolism. Keeping in mind, we have also to look for has blood score, assess the risk of bleeding in the patient. If it is high, it means that we should modify these risk factors, and it is not an indication that we should not anticoagulate. And you all know the indication. So if you have patients with mechanical valve, moderate to severe mitral stenosis, they are high risk. We have to anticoagulate them. And for the time being, we have only vitamin K antagonists, but there are ongoing studies evaluating oral anticoagulants again in this group. If they are not, we look to CHA2DS2-VASc score 0, no need for anticoagulation. 2 or more in males or 3 or more in females, anticoagulation and NOACs is preferred, of course, over warfarin. We know that NOACs is effective, and if you look to the risk of stroke and systemic embolism, they are as equivalent or even better than warfarin. Major bleed is reduced, intracranial bleed significantly reduced with NOACs, but if you can look also there is still problem with GI bleeding. So we know that NOACs works in the two pathways, the contact pathway, and this is actually helpful because it prevents intracardiac thrombus, but at the same time, it blocks the tissue factor pathway. So when there is vessel damage, it prevents thrombus formation and leading to bleeding. The notion now with the new oral anticoagulants is factor 11 inhibitors. And the theory behind it, if we use the factor 11 inhibitors, it affects the contact pathway, so it has the same effect of preventing intravascular thrombus, but does not affect tissue factor pathway, so does not stop clot formation when there is bleeding. In a recently published study, Pacific AF, looking to a Sandaxian, which is factor 11 inhibitor, using 2 dosages, 20 and 50 milligrams, compared to abaxipan, 5 milligrams twice daily. And the primary safety here is looking for bleeding. There was significant reduction in major bleed, minor, and all bleeding compared to abaxipan. More than 50% reduction in bleeding. However, this is still phase 2 study. Phase 3 is awaited, and looking in phase 3 about the efficacy in stroke prevention and also bleeding risk. Other way to avoid bleeding with anticoagulation is left atrial appendage closure. It's there for some time now. We know different devices endocardially, epicardially. And we still see more studies evaluating their use, like in this study, for example, in patients with high CHA2DS2-VASc score and the high HAS-BLED score. It was effective, actually, and there is reduction in ischemic stroke, major bleeding. About 85% were in single antiplatelet. In subset of those patients who were only on one antiplatelet or not on any antithrombotic agent after 3 to 6 months, their risk of a stroke and their bleeding risk was low, 1.4 per 100 patient year. So still, it is good if you can avoid anticoagulation and keep patient on one antiplatelet or no antiplatelet. And looking to the guidelines, percutaneous approach to LAA closure is still 2B in patient who has contraindication to long-term anticoagulation. Cardiac surgery, LAA occlusion, I don't have time to go over it, but we know that it is effective, and if the patient is going for surgery for any reason, it is good also to do LAA occlusion. A couple of years ago, there was a study looking to CABG patient, and they did LAA occlusion. They don't have atrial fibrillation, and actually there was significant reduction in ischemic stroke later on. Okay, I'll skip that one. For better symptom control, there is more concentration nowadays on early rhythm control. We know for some time after a firm study and others that maybe rate and rhythm control are equivalent, but new studies like EAST study, when they looked for over 2,700 patients randomized to early rhythm control versus usual care. Early rhythm control were in antiarrhythmics, mostly flecainide, and some underwent ablation early and some underwent ablation later on to keep the rhythm. And it was more efficacious to keep them in rhythm control compared to usual care. When they look to a pre-specified group, which is patient with high CHA2DS2-VASc score 4 or more, compared to those with less than 4, sorry, I'll go back. Still, it was efficacious to go for early rhythm control in this high-risk patients, compared to patients with low CHA2DS2-VASc score. And when they took actually the 6 ginger out of the equation, it was effective. So basically, I think what is different in this study compared to the previous studies that it includes patients with recent atrial fibrillation, i.e. 12 months or less, high rate of atrial fibrillation ablation in this, which is 8% and up to 20% by 5 years, but it is still single-blinded study. Cardiovascular and other comorbidities risk reduction is well known. So if we reduce if you control diabetes, hypertension, dyslipidemia, weight reduction, treat obstructive sleep apnea, stop smoking, this is very beneficial in reducing cardiovascular morbidities and mortalities, including stroke. So in conclusion, atrial fibrillation is a cardiovascular pandemic with complex pathophysiology and contributes to significant morbidity, mortality. Some guidelines, like European guidelines, recommended screening for atrial fibrillation in specific population. But I think it is still debated because I showed you the studies that did not show significant benefit. There is maybe a downside of these studies. Stroke prevention is highly relevant in patients with atrial fibrillation, and we see nowadays new oral anticoagulants help. Hopefully, it will reduce risk of bleeding with the same efficacy in preventing thromboembolism. Again, left atrial appendage closure has increasing role. There is more interest now in rhythm control, early rhythm control, and keeping sinus rhythm. And as you have seen before, that atrial fibrillation ablation is very effective, and it is superior to antiarrhythmics and should be first line in some patients, actually, like if they failed antiarrhythmic medications. Control of atrial fibrillation risk factors, I think this is the most important. Patients with risk factors, we have to control the risk factors to prevent thromboembolic stroke. Thank you very much.
Thank you very much, Dr. Bandar Alghamdi, for this